I'm Dr. Stephanie Martin, maternal fetal medicine specialist and medical director at Clinical Concepts in Obstetrics. Common neurologic changes that happen in patients with preeclampsia include hyperreflexia, and it is not unusual to see patients with quite brisk reflexes and even clonus. Unfortunately, hyperreflexia does not correlate with the severity of disease or predict those patients who are at risk for developing seizure. All patients with preeclampsia, and particularly those with severe features, are at risk for developing seizures called eclampsia. Headaches are quite common. Vision changes such as spots in the vision, and even temporary blindness can occur. Now, the temporary blindness may be a result of cerebral edema in the occipital region, or this could be due to retinal detachments from severe hypertension as well. Now, if a patient has preeclampsia and develops a grand mal seizure, we change the terminology to describe it as eclampsia. It is completely unpredictable, and the farther the patient gets from her delivery, the less likely it is to occur. And this is one of the reasons why we recommend delivery prior to term in patients with preeclampsia, is to avoid the development of seizure, among other potential complications. Your patient may have symptoms that precede the seizure, such as visual changes, headaches, or changes in mental status. But unfortunately, we are very limited in our ability to predict those patients with preeclampsia who will ultimately go on to develop a seizure. Some of the pulmonary changes that can happen in preeclamptic patients include primarily cardiogenic or non-cardiogenic pulmonary edema. Now, these patients can develop either type. And so pulmonary edema is known to be a complication of preeclampsia with severe features, but it can be cardiogenic or non-cardiogenic. And that's a very important thing to understand to be able to differentiate. Non-cardiogenic pulmonary edema is fluid in the lungs that develops independent from whether there's a cardiac issue. This is not an overflow of too much volume from the heart. This is fluid leaking from the vessels into the lung spaces. Cardiogenic pulmonary edema may also develop if your patient has excess volume. And in some cases, the severe hypertension that occurs, if it's not dealt with in an effective manner, can decrease cardiac output and contribute to risk for cardiogenic pulmonary edema. And it is possible for your patient to have a component of both. It is important to know that magnesium sulfate is the recommended therapy for prevention of eclampsia in patients with severe features. Magnesium sulfate should be continued throughout their labor, their intrapartum period, even if they have a cesarean birth, and should not be discontinued due to concerns of or the development of pulmonary edema. Prevention of seizures is the priority there, and magnesium sulfate inherently itself does not cause pulmonary edema. However, careful attention to ins and outs, how much volume is going in and how much is coming out, is excruciatingly important in these patients, as magnesium toxicity can develop and your patient can end up with excess volume if we're not careful about monitoring what's going in and what's coming out.